the soul of a physician and entrepreneur. So we want to dig into the soul and understand how physicians are innovating. And we bring in some of the top examples of physicians doing innovative things and being successful at it. So we'll talk a lot about today's guest, and she is here, Dr. Leah Houston. Dr. Houston is an emergency physician, just like me. I used to be an emergency physician until I retired, took early retirement 6 years ago and started InnovatorMD. She's also a technology entrepreneur. She's building the future of healthcare infrastructure. She's the founder and CEO of Evercred. She's leading the shift toward AI-powered credentialing system. I know a lot of us have had a lot of difficulty with credentialing and the burden and how do we bring clinicians on into a new system very quickly and efficiently? And that's what Leah Houston is working on. And she has over a decade of clinical experience and background in technology innovation. She is redefining how healthcare systems think about efficiency, trust, and workforce mobility. My name is Yuli Cheripalli, and I'll be your host. And Dr. Houston is our guest. Um, Dr. Houston, how are you doing today? Welcome.
I'm doing great. Thank you so much. That was a really generous introduction.
Thank you. I know we met, I don't know, 6 years ago, or I remember a phone call, coming from you and talking about what you were planning to do, maybe 6, 7 years ago.
Correct.
Um, so how is life in general, and how is the company? What are you up to these days? Give us an update on what you're doing.
Yeah, life is great. The company has evolved. I had this very idealistic idea in the very beginning. I heard and felt not only my own frustration, but everybody else's. And I thought that there was enough fuel in that frustration to create systems of organization. And I rallied together hundreds of doctors, and we had this concept of, you know, not just a credentialing tool, because credentialing was one part of it, but essentially owning our right to work, owning our right to move, owning our relationships with our patients and each other. Right now, the referral networks are largely owned by insurance companies, large vertically integrated hospital systems, and it's part of why physicians are feeling disempowered. So the initial idea was more of um, a community that identified doctors and had an identity layer, because our identity as physicians is really our credentials, our medical degrees, our licenses, our residency certificates is what allows us to do what we do. Um,
By,
and
by the way,
that's Yeah.
by the way, I still do have your HPEC T-shirt that you sent me.
Oh, I love
Thank
that.
you. Was that the name?
Yeah, so HPAC stands for Humanitarian Physicians Empowerment Community. It was more
Yeah.
of a community and an organization, and anyone who invested on the crowd fund at a certain level got a t-shirt. Some people got a mug, things like that. And
Yes.
so,
Yes.
yeah, and the company is still HPEC. The company is
Okay.
still Humanitarian Physicians Empowerment Community. It's HPEC Inc. It's a Delaware C Corp. But the new product is Evercred, and
Got it.
that's the new product. And we're focused on credentialing first because that's a
Yeah.
real problem that needs to be solved. But we still want to do everything else. We haven't given up on that vision.
All right. All right. Let's talk about. Let's go back. Um, we want to know what makes Leah tick. We want to know how it started, where it started. Can you tell us a little bit about, growing up, your, you know, school, college years, and how did things shape you as an innovator?
Well, it's kind of funny because I'm actually sitting in my great uncle's office, his study. Uh, he's a geophysicist, mathematician. He studied the magnetism of the earth,
Hmm.
and He was the only one in my family that had gone to college before me. And so
Wow.
he was my grandmother's brother. And so, both of my parents, my father was an artist, my mother was a hairdresser, but he actually, influenced me on the mathematics and the scientific side. And he actually kind of tutored me a little bit in calculus when I was having a hard time with calculus. Um, so, I do have some family members that have like a scientific background, but my parents directly were more on the artsy side. And so, yeah, my father was a goldsmith and a sculptor, and my mother was a hairdresser, and they were, hippies of California, and kind of encouraged me to do whatever I wanted from a very young
Yeah.
age. Never felt pressure to, excel. It was really pressure that I put on myself, and I enjoy learning. I enjoy challenging myself. So, yeah.
Where in California did you grow up?
So I was actually born in Monterey. My parents met in
Oh,
Santa Monica. I was born in Monterey. They lived in Carmel for a bit, and then we moved back to New York when I was a small child. And that's where I did medical school and residency. So I was there for most of my adult life until I got married, moved to Florida, and that
yeah.
stuff. Yeah.
How did you pick medicine? I mean, you could have become an engineer, you can become an artist, you can become. How did you pick medicine?
Well, so there was a couple of things that influenced that. Number one, there was a lot of things I really loved. I loved art. I did art all my life as a child. My whole house was an art studio growing up with a father who was an artist. I loved learning about history. I liked debate and model Congress. I thought about going to
Hmm.
law school. I did, student government. I did lobbying and things like that. But I also really had an aptitude for science, chemistry, and physics. I mean, when I was able to look at a substance and understand what it was on a molecular level, that was really cool. I thought that was, and I thought it was really interesting how mathematics can describe essentially our whole world. And so at one point, I said to myself, okay, if I'm going to dedicate my life to learning something, do I want to learn the laws of man, which is, law, history, all these other things, or do I want to learn the laws of science, of the universe, of
Mm.
God? Things that are, and even though there's now with quantum physics and Newtonian physics, there's kind of some conflict with whether or not Newtonian physics is always applicable to every situation. The fact that we could learn these theories that can be applied to our environment in order to understand the environment around us, and no matter where you live, no matter where you are in the world or the universe, they apply to some extent. I thought, okay, I'm going to learn that thing instead. If a
Mm,
government
mm.
collapses, my knowledge will still be valuable. Um, and emergency medicine, um, you know, kind of a doomsday prepper kind of person. Okay, end of
Yeah,
the
yeah.
world. Who's going to be allowed in the spaceship? Who's going to be, it's going to be the physicians first, builders, farmers, but especially emergency doctors. So uh,
Yeah,
there's a combination of those things that pushed me in that direction.
yeah, yeah. Did you have any mentors at that stage where, physician mentors who were, who you saw work and said, "Oh, I want to do that,"
So
or what was the influence?
my uncle Jody, my cousin's father, was an emergency doctor. Um,
Oh,
so I did see him growing up, working, and I also grew up with no health insurance, and neither did my parents. So anytime we
mm.
had any medical problems, real medical problems, we would be in the emergency department. So that's really all I knew. Um, but as far as mentors go, my high school physics teacher, Frank Parisi, he really influenced me to go to medical school. He's the one that planted the seed in my brain. I didn't even consider
Yeah.
the possibility. Um, John Burton was the residency program director, and he mentored me throughout medical school. And then Howard Snyder was one of the attendings that I really admired. And I also had in high school, I was an organic chemistry tutor, that was kind of my, if things don't go well with med school, maybe I'll go
Backup plan.
into organic chemistry. So Dr. Dexter Chris was very influential also in undergrad, who's my organic chemistry professor. So I had a lot of people that I really respected who kind of made it even more exciting to learn.
Yeah,
So yeah.
yeah, yeah.
Mhm.
Now, I know I what I've noticed is that a lot of my colleagues, I mean, in general, emergency physicians, they go into innovation and entrepreneurship. I don't know what it is. What attracted you to emergency medicine in the first place? What was it about emergency medicine?
Um, I liked that you could live and work anywhere, that you could control your schedule, and that I didn't want to have my own private practice, despite the fact that I'm now, a founder and I have my own company and all the things that come with it are very similar to what comes with owning your own private practice. When it came to medicine, for some reason, I felt like this is sacred. I want to take care of anyone, regardless of their ability to pay. I want to know that I can always do the right thing without being influenced by any kind of external influence, whether it's insurance reimbursement or whatever. And I also liked the idea of having, I felt like it gave me a purity of thought. Um, and then you get to take care of everyone, old, young, rich, poor. And so the variety and the ability to kind of really help people in their worst moments. I think the
Yeah,
combination of all of those things were really what was appealing to me.
yeah, yeah. Now, uh, the freedom and the flexibility, I just love it. Although I never traveled much, as far as job is concerned. But how many places did you work at in your
I
career?
I worked at 14 different health systems across 3 states.
Wow.
Yeah.
Nice.
And that's how I
So
got
you,
familiar with the credentialing, rigmarole and,
yeah, yeah.
the friction that comes along with it.
Are you more like explorer type where you want to go to a new place and see what's happening there and want to learn new things? Traveler? What are your side I should say interests that make you try all these different jobs in different places?
I always think changing up your environment helps ignite innovation, helps keep you curious, helps keep you on your toes, helps keep you learning. Even if, when you're stuck in a rut, they recommend small things like taking a different route to the grocery store, going to a different grocery store than you normally go to, just to kind of, switch your brain energy. And I think that being able to work in different places, it was important to me to keep my skills up. And
Hmm.
whenever I was in a place for too long, I started feeling like, okay, I'm not learning anymore, you know?
Uh,
Um, and so that was part of why I liked to move around a lot. And it worked, different places had different access to different things. I used to use cocaine for bloody noses a lot. Go to a place, they look at me cockeyed if I asked for cocaine in some places. So yeah.
the fun times. Uh, the other thing I think, I don't know if you felt that way, but emergency medicine is where you get to see the whole system. You know,
Yes.
you have, you are connected to every department, both inside the hospital and outside, whether it is, fire, paramedics, the whole nine yards, right? Police. And so you are actually, I call it, when you take a glass of water and you put some mud in it and mix it, and you look at it from the bottom. I think that is what emergency medicine is, where all the ills of the society, they will come, end up there, settle there. Because any system, anywhere, if it fails, that's where you end up, whether you're caught in a hit and run, or somebody shot you, or your doctor doesn't open his clinic that day, or any disaster anywhere in the system will end up there, right? I mean,
Well,
do
that's
you
what I
feel
loved
that?
about it. We were the
Yeah,
safety net, and a lot of people that we saw had not ever seen a doctor, or like in my case growing up, we were the only place that they could get care. I really feel like a huge, huge impact is able to be made in the emergency department. And, like you said, we kind of have to be connected to every specialty and to
yeah,
know enough, at least about the emergencies of every specialty. And when things, I mean, we're the ones that decide, do you get admitted or discharged? We're
yeah.
we're kind of the opportunity to get access to the things that you need. And that was also one of the things that I was surprising was so hard. Because some places they didn't want me to admit people that clearly needed to be admitted,
Yeah,
and vice
yeah.
versa. Where some places were pressuring me to admit people that didn't need to be admitted. It was very strange, and I did not expect that at all. Yeah.
So, tell us about a place where it was the weirdest experience for you as an emergency physician, and other people don't realize how these places work, or something that you remember very well from your experiences.
Well, I worked in California in San Francisco, and it was downtown. And I want to say the majority of the population were likely socioeconomically disadvantaged, underinsured, uninsured, and a significant number were addicted to methamphetamine, fentanyl. A lot of the stuff in the Tenderloin of San Francisco, you
Yeah,
see people hunched over and in the middle of the day in broad daylight, and people living in tent cities. These were the people that we took care of. And in this particular place, it was grossly understaffed to a dangerous level. I remember one particular day, there were two back-to-back patients who came in extremely agitated. They were handcuffed to the beds. They put nets over their faces so that they can't
mm,
spit at you. And in every other hospital I'd ever worked in every other state, when a person like that came in, they would usually be under arrest because they were found doing something. This
yeah,
particular person had been found jerking off outside of a school, one of them. And in other hospitals, the police officers stayed with them because they were under arrest.
yeah,
And in other hospitals where they weren't under arrest, we had a one-to-one sit for safety.
yeah,
Now, in this particular hospital, um, the officers never stayed with the patients. We did not have staff for a one-to-one sit, and we did not have psychiatry on call. And the department itself was grossly understaffed. So we already didn't have enough nurses and ancillary staff. So these patients were very, very much at risk and in danger if they were being left
yeah,
with me, because they could thrash around in the bed and end up crashing, onto the floor if they didn't have a sit available. If there was not enough monitors available, we could think they're sleeping and they're dead, And so that was a very dangerous place to work. And when I brought it up to the leadership there, um,
mm.
they basically were like, "Oh, maybe you're not fit for emergency medicine if you can't handle this. This is just how we do things here." And I'm like, "Oh no, 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 no. This is not acceptable. This is dangerous." Um, yeah. So that was really one of the most disappointing experiences I had, because these people really need care, and they need the right disposition, and they're just going to keep cycling back into the emergency department if they don't get the right care, if they don't have social work to properly, give them a disposition where they can get help, adequate help for their drug and alcohol addiction, housing support. It was just really
Yeah,
sad. It was really sad.
that's true. I mean, yeah, I can imagine. I trained in South Central Los Angeles, so I kind of know the situations that residents are put through,
No, this
right?
was an attending.
You are an attending.
I was
Okay.
attending.
Um,
Yeah.
So how I know that with your traveling and trying different jobs, you had to obviously get licensed and stay in different states. And how many states do you have a license in?
California, Florida, and New York. My Florida license lapsed last month because they're gonna try to make me do fingerprints again. I'm like, why am I have to do fingerprints again? I've already done them. My fingerprints aren't changing. Like, what is going on here? And so I just didn't have time to schedule it. So I don't know if they're gonna let me do that now that it's late. We'll see. But yeah, so California,
Yeah,
New York now, but previously also Florida.
Florida.
Yeah.
Mhm. I guess that's a big big catchment area for emergency medicine, right? Those
Yeah.
three states, pretty.
Yeah.
Um, so tell me what attracted you to solving this problem? How did you find this problem in the first place? I know that you were applying, but how did you think that this is a problem that needs to be solved? Why do you think?
Well, having worked across the United States, I did it through locums. And so with locums, you essentially are filling in, they're not able to find full-time staff. And what most of us do, even W-2 employees, when we get a contract, maybe we negotiate it, maybe we read the fine print, but most often we don't. And if you look at the fine print, it essentially says, sign here and you give us the right to use our credentials whenever we want.
Hmm.
We have the right now to bill under your name. And when you're reading it and you're first applying, you're like, of course, like they need to be able to bill under my name if I'm working there. And you assume that that means they're only going to bill for things, services you're actually rendering, right?
Hmm.
Now, um, I had been working at a hospital that after I left, they were continuing to bill under my name,
Hmm.
committing Medicare and Medicaid fraud.
Wow.
And it actually was in Florida. And right now, my license has lapsed in Florida. And back then, my license also had lapsed
Hmm.
for similar reasons. And I wasn't working there anymore, but they were billing for services that I wasn't rendering in a hospital I was no longer working in a state I was no longer licensed in for that period. And it
Like
made
for patient care? Like billing
yes,
for patient care?
yes,
Really?
yes.
Wow.
They had a nurse practitioner seeing the patient, and they
Oh.
had me supervising, but I obviously wasn't supervising.
Hmm. That's scary.
Well, so it made it appear as if I was practicing medicine without a license, and
Yeah.
I had my privileges to bill for Medicare and Medicaid revoked. And I
Hmm.
had to basically prove that this was a mistake. And that was a 6 month, very difficult legal battle to prove that they were illegally using my credentials and committing fraud and that I wasn't actually practicing medicine without a license. So
Wow.
that,
And
yeah,
does that mean when Medicare gets involved, it means you lose your ability to practice anywhere in the country?
most emergency departments because you need to be able to bill
Basically,
for
right?
Medicare and Medicaid. Yep. Right. So I was unable
Wow.
to work for those 6 months.
It's not just Florida.
Yeah, unable to work anywhere.
That's scary. How did it resolve?
Well,
Just
fortunately, I was actually working at that shit show of a hospital that I mentioned in California on the exact same days that they claimed I was being, working in Florida.
ah,
So, I was able to prove that I wasn't working in two places at the same time that were that far apart from each other.
yeah.
But what if I'd been on
Wow.
vacation during those days? What if I had taken a sabbatical? I don't know how I would have proven it, you know?
Yeah, yeah.
Um, but, that combined with the disempowering experience of not having the resources I needed to properly care for people in that hospital in San Francisco, combined with the disrespect of using my hard-earned credentials that took me 11 years of intense training and hundreds of thousands of dollars to obtain, and disrespecting me by using them without my consent, to treat patients and to make money off of my hard work and labor. Um, it was so infuriating to me that I said, I
Yeah.
need to fix this. We need to fix this. And I went out to fellow colleagues and I talked to them about what happened. And I learned that a lot of other people had had similar, I mean, even to this day, every couple of months, somebody randomly finds me and says, "Oh my God, I heard a podcast where you were talking about what happened to you. That happened to me." And um, so this is far more
Mm,
common than people realize. And so this is why I started the company. This is why I started the Humanitarian Physicians Empowerment Community to essentially restore our autonomy, agency, our right to practice, to work for, and move freely, and to serve patients without third-party interference.
mm, mm. So, so does that mean that the system, is it just that physicians are excluded from these things that happen outside, or is it more um, more sinister than that? You know, how does that fraud happen? I mean, I'm sure they can say, yeah, well, we didn't know that that physician had left already, and so we were just billing. Was it done like with malicious intent or knowingly, or how did that happen?
I believe
Wow.
at this particular hospital, which I actually really loved working there, I
Mm,
believe it was a combination of a clerical error. Um,
mm.
but if you have the tendency to make a clerical error that generates revenue and makes you money and nobody ever
Oh
really
yeah,
notices it, then you're also not going to try to not make that clerical error. If you know you're not being watched, right? I
yeah,
don't think it
yeah.
was intentional. Oh, Dr. Houston left. Let's make sure to keep her on the schedule. Like, I don't think it was that. But
Okay.
the fact of the matter is we have all of the responsibility and none of the recourse. You know,
Yeah,
we sign away our, rights to bill under our credentials, and they basically like, you take all the liability when we do this. We don't have any liability, and that's true. Legally, we have the liability to keep track of our licensing, our credentialing, our PCOS, um, and things like that. And so, we don't really have any agency, and that's part of what I was hoping to be able to fix, and what I am still hoping to be able to fix with our new tooling.
yeah, yeah. Now, you see this problem, and then you hear from other people that yes, this is a problem, and you try to diagnose why it happens or how it happens, or what are the systemic issues that make this kind of a problem happen? What are the bigger picture areas that you found from your research while solving this problem?
Well, I think that we need to take it back to um, two things that are essentially controlled mostly, for the most part, by the American Medical Association. And one of them is the ICD-10 coding handbook. Um, and the other one is the RVU incentive payment program. So that combined with the incentive for people to purchase insurance in order to obtain medical care, uh, the combination of those things is what I believe has led to this problem. It's the third party interference with the practice of medicine. It's essentially documenting everything that we do, putting codes to it, putting values to it, and essentially creating a surveillance system over how we practice in order, it's surveillance capitalism. They're
Yeah,
surveilling our behavior and they're capitalizing on it. And from my perspective, they're capitalizing on the pain and suffering of patients.
yeah,
Um, and so a lot of people don't know the history, but the American Medical Association got itself into a lawsuit because they were illegally, I don't want to say illegally, they had this membership organization and they had a bunch of people who wanted access to the doctors, a bunch of companies, and they made a
mm,
deal. There's actually two things that led to this. They made a deal with Sunbeam, which was a medical device company, And so they
Mm,
were essentially promoting these medical devices amongst the physician community without disclosing that there was a financial incentive for them to do that. And the physician community found out, and that's when they started to kind of lose trust for the AMA. And they sued the AMA and lost the lawsuit. And then there was also a lawsuit even earlier than that. People have heard the term quack. You know, way before that, there was a lawsuit, I think it was in the 70s, don't quote me on that, where chiropractors were essentially wanting rights to prescribe and all these other things. And the AMA said, no, these guys are quacks and, they only medical doctors can practice medicine. And essentially, they lost that lawsuit as well over antitrust. It was an antitrust loss. So the combination of those two lawsuits, the AMA essentially, from my perspective, um, it seems like they made a deal with the devil and said,
mm,
okay, as long as you don't decimate us in our organization, we're going to now do your bidding, government of the United States. You give us the exclusive right to publish the ICD-10 coding handbook, and you give us enough board seats on the RVU incentive payment board, and we will do as you tell us to moving forward. And so
mm,
it's really kind of interesting that they lost an antitrust lawsuit and they have a monopoly over the ICD-10 coding handbook. And they're the only ones who legally are allowed to publish that. But if I'm remembering correctly, this is the historical background between, this tool that now is used to surveil our behavior and to allow insurance companies to essentially index what we're doing in order to determine the value of it, in order to determine what they're going to pay for it. And so, from my perspective, once that all started happening, once patient and doctor were no longer the only ones in the room, once we had these incentives from insurance companies, once we had employers paying us rather than us owning our own private practice, we essentially were completely disempowered from having any control over our professional lives and our professional destiny. And unfortunately, patients now think that we don't care.
mm, mm.
And that's the biggest
Yeah,
tragedy
oh,
from this.
yeah. Patients don't realize how much of the pie these middlemen get out of what they're being billed, and how much of that is actually physicians' slice. Um, so I mean that's a huge problem to take on. um, right? Uh, but then there are the hospitals. Okay, so they have their own incentives. They have their own things. Of course, the insurance companies. Um, what are the incentives for AMA and the physician groups? What is in it for them? I mean, other than advertising dollars for pushing, things our way, what is their incentive? What else
Well, I mean,
is?
the AMA also publishes the master file, the physician master file.
Mm,
Um, I was essentially pressured to join the AMA in medical school. So they go into the medical schools, they have access to medical school, they incentivize people to join, you know, it, it's funny, Will Flannery, MD, the ophthalmologist who does all those skits, he does the one skit where he
yeah,
keeps finding AMA mail everywhere. It's like all of us, they keep getting mail for the rest of our lives from the AMA to join.
yeah.
I mean, listen, I think our national and regional medical associations, some of them are doing the best that they can, but some of them have been failing us.
Mm,
And, I understand, people are put in a hard situation like the AMA. They're like, you know, make agreements and, do what we need to do to survive or die. And so they
yeah.
kind of did a bunch of stuff for a while that really was not in the best interest of doctors. And from what I can tell, they're, starting to kind of try to fix that. Um, but I think it might be too little, too late. Our profession has been decimated, in my opinion, in many ways. The non-physician practitioners coming in and practicing without supervision, The downward pressure on reimbursement and on our salaries, the ever increasing onerous administrative tasks, not only in credentialing, but everything else. It's making it not worth it to practice for a lot of people, you know,
Yeah, yeah,
and the patients are the ones that suffer in the end, and
of course.
they don't really I mean, I don't even understand the complexity still. I know a lot more stuff than I did, but it's super complex. It's super complex to unravel it.
Yeah, yeah.
Yeah.
Now, what is the role of the medical board, state medical boards in this? Obviously, they're not making it more efficient or more smoother, or what's your take on the medical boards?
Well, I mean, I personally think, the medical boards, it's kind of like a vestigial organ. They've
Mm,
been there. There's no reason to remove them. They're making money. They have their systems in place. Um, but from my perspective, I believe medical licensing should be like driver's licenses. I believe you should have one state, your main license, but you can drive across state lines and it's still valid, right?
yeah,
So
yeah,
I believe that we should have interstate medical license reciprocity amongst states. And I don't think that there's any legal reason that that can't be. I think the only reason that that's not the case is because of this vestigial way that these medical boards are, and the fact that they do make money off of the licensing process. But I also want people to realize, like, we as physicians, we have a license to practice medicine and surgery.
yeah.
We don't have to do what they tell us. The only
Mm,
reason that we feel like we have to do this and follow this protocol is because we've accepted insurance as payment. But, there are lots of physicians who are seeing the value and the benefits of stem cells, exosomes, peptides, things that aren't yet FDA approved. Like, there's a right to try, and we have a right to try with our patients as long as we appropriately discuss and document informed consent, you know?
mm.
And so I think that the value of a medical license is a lot more valuable than people realize. And so I think that that's, yes, the medical boards are, you know, they're helping in some ways and harming in some ways, but we also get a lot of benefit from having these licenses. And if we, create systems where it's easy to practice, easy to open your own private practice, easy to collaborate, to refer, which is what we're trying to build tools for, um,
Yeah,
then we can kind of take back medicine and take back and restore the privacy and the trust that we once had with our patients, which is what we'd like to do.
yeah, yeah. I mean, plus a lot of it, comes down to how we push policy making that is more physician friendly. Have you had any experience in that area? Have you pushed any, whether it is reciprocity? I
Yeah.
don't know if I'm saying it right, but is there any push on the policy side, do you think?
Well, so I spent a lot of time in DC and on their state and national, you know, assemblymen and senators discussing these things. And the fact of the matter is that our voice is listened to as
Mm,
physicians when you participate. But money is what really moves this stuff. And unless you have
mm,
a huge number of people moving in unison, which physicians, we are so individualistic, it's really hard for us to come to an agreement on things. Or unless you have an enormous amount of lobbying money behind an effort, it is very hard to pass something because
yeah,
people have, like the ACA. I remember when that was being passed, and I remember like I read the whole thing, it was very long. And I remember thinking, I love Obama and I know what he's trying to do here, but there's a lot of stuff in here that's very bad and it's going to
yeah.
hurt us and it's going to
It's,
hurt patients. And the thing is like even legislators, like they have to make concessions and agreements to get some things passed. Did he make the right decision? I don't think he did. With the incentivization of insurance, because if you look, there's this runaway cost, and
yeah,
the what happened recently with the, people don't realize that the reason the government was shut down for such a period of time was because they were having a disagreement over whether or not to extend the tax credits around paying and supplementing for these outrageous insurance prices. And but what people don't realize is these are artificially inflated prices between the
Yeah.
PBMs and the GPOs and the backdoor deals and the monospemy energy between the insurance companies and the hospital systems. They are layering in and excessively overcharging the American public for healthcare. And the ACA did that. Unfortunately, that's my opinion. Um,
Yeah. Yeah.
so, and then there's a lot of, the physician community is kind of divided over whether or not we should have universal health care, or whether or not it should be cash pay. And even the people who do agree, oh, we should have universal health care, they don't agree on how it should happen. There's a lot of nuances in this stuff. So, for example, the Bernie Sanders plan, it essentially compelled doctors to take Medicare and Medicaid. You weren't allowed to refuse Medicare and Medicaid. And so it
Mm.
essentially created indentured servitude. There's no other profession that does that. I mean, this is the United States, this is America. We just had our 250th birthday. You know, we,
Yeah. Yeah.
right to work, freedom, like that's what our foundation is. So stuff like that's not going to fly, with people like us.
What
So
what do you see as an ideal system in your experience and in your view? What would be ideal, you think? Make it all cash pay? Is that what you're
no
saying?
way, no way. I think an ideal system in the United States is difficult to discuss.
Yeah.
There's a lot of things about the US. Number one, we're a cultural melting pot.
Yeah.
So a lot of the other countries that have really, really good systems are not only much smaller countries, but they are, they're one culture of people that kind of have
Yeah.
similar value systems regarding, all kinds of things. I mean, we take cultural competency in medical school and we learn, hey, this culture rarely complains of pain. This culture oftentimes over exaggerates their pain. Just keep that in mind. And, even though there's some, racism and biases that are kind of ingrained when they teach these things, there is some truth to them. And we have to learn some of these differences because America is such a melting pot. So I think it's a little hard to say what the best system would be, but I personally think that we should have um, a public option for everyone, where everyone can buy in to a Medicare Medicaid like system. And for people who are at certain socioeconomic statuses, or people who have, elderly children or people with disabilities, mental health issues, they automatically get it. And I think, if people had the option to buy into the government system, then it would stop this runaway private health system stuff and would force them to control costs. I also think that we need to get rid of the PBMs and the GPOs. I think they're middlemen that drive up the cost of things. Mark
Mm.
Cuban is trying to do that a little bit with Cost Plus, but like, there's no reason insulin should cost so much. There's no reason that a kid who has a peanut allergy shouldn't have an EpiPen because they're too expensive. Epinephrine is very inexpensive. It's cheap.
Mm.
You can get it from Henry Schein for super cheap. Why are we overcharging these poor kids and putting their lives at risk essentially? So get rid of the nonsense, get rid of the third parties, make a public option available. I also think that uh, we don't do a good job in general of creating services for people. If you look at
Mm.
Sweden, for example, the prison systems in Sweden actually help people. People who have mental health problems, they really help support their mental health issues and they get them the right services while they're in prison. And then they continue those services when they leave. Um, Same thing with alcohol and drug, and violent offenders don't get let out, they stay.
Mm.
And so I think that, you know, really fixing how we do the long-term stuff, making sure that we actually follow up with people, I think that would change a lot of things. One of my issues is the foster system. A lot of people don't realize that like one third of the people experiencing homelessness were children that aged out of the foster system. It's like imagine
Mm.
being 18 and now you're alone in the world and you have nowhere to even go home to for Christmas or Thanksgiving. You have nobody to call you on
Yeah.
your birthday, and you're just out. Of course, you're going to be more likely to turn to drugs or to commit crimes or to have mental health issues because of the stress that comes with that. So, we're doing a really bad job of taking care of single parents, young single mothers and parents. A very bad job of taking care of the foster system, very bad job on mental health. And so I think that if we also fix those things, the downstream effects would be enormous.
Mm-hmm. Now, tell us about the solutions that you're building. Tell us a little bit about what you're building.
Well, every physician I know, like you're an emergency physician, but you're also the founder of, this podcast and Innovator MD and this new hospital system. And um, a lot of people are super specialists. There are super specialists in this country who are like only take care of people with neurofibromatosis, which is super rare. So I think that we are not doing a good enough job of putting people where they should be, of creating access to the people that need to have access to certain types of care. We're not doing a good job of referrals. Um, and, there's a lot of waste. So I believe if physicians have their data, their credentials, and an ability to quickly work and move freely and go certain places and even do a telemedicine consult quickly and easily for a patient that otherwise wouldn't get a chance to see a
Mm.
second opinion for this urologic issue. Um, we not only would restore autonomy to our own right to practice and to work, but we would create an access for patients. And so the long-term goal of what we're doing with Evercred is for us to be able to work and to move freely and to serve patients unencumbered by third parties. Whether it's collaborating with each other in order to build private practices, hospital systems, or being able to refer patients and aid in patient care in innovative ways that otherwise wouldn't be there.
Yeah. So you're seeing the current credentialing system as a barrier to access, not only for physicians, but also for patients. Or am I, did I summarize it right? The
Yeah, it's really
problems,
interesting because there's a
solution
lot of
statement?
yeah, there's a lot of people who are like, "Oh, credentialing's no problem for me. My administrator takes care of it." It's like,
Yeah.
okay, well, it's no problem for you because you work in one place and you don't want to work anywhere else, and you haven't even considered the possibility that that's even possible because, there's it's such a blocker to even consider that you could work
Yeah.
anywhere else. It's credentialing that keeps you stuck. Like, I would be working right now if it wasn't for credentialing. I get, text messages all the time. Hey, can you work here? Can you work there? Like, I've been a founder, for a long time. Making a few extra $1,000 a month at a shift here and there would be very helpful to me, but it's not worth it because the credentialing is
Yeah.
too much work. Um,
Yeah.
and so I think that there's a lot of opportunity that will come with automated credentialing. And I just want to be clear, like people are like, "Oh, I don't need to be credentialed. I take cash." Well, you still need to be licensed, and
Yeah.
licensing is under the umbrella of credentialing, you know?
Yeah.
So yeah.
Now, you know, uh, I mean, obviously, you have taken the grassroots approach where you want physicians to come into this umbrella, and then there'll be a groundswell where okay, suddenly the whole system changes. Um, have you considered like what if you go to these medical boards and say, hey, you're doing all these things and our hospital boards and say, I have an easy solution. Can you come from the top or would that not work?
Well, our customers are going to be hospital systems,
Mm.
anybody that credentials doctors. And, we have discussed collaboration with different medical boards, state medical boards, things like that, because they want to offer tools to their members, right? And this is
Yeah,
a
yeah.
tool for freedom and mobility. Um, and so, yeah, we are in the process of having those conversations. So if anybody who's listening is on the board of
Mm.
any hospital systems, of any state, national, regional medical associations, we can offer, non-dues revenue for revenue shares. and give big, deep discounts to your members because we want to collaborate and work with the systems that want to help doctors. You know, we want to work with other people who want to help make our lives easier and make it easier for us to want to care for people.
Yeah, yeah, yeah. Um, uh, Tell us a little bit about your business model for your startup. What is the business model?
Yeah, I mean, so the business model, we're doing some things that are a little bit unique. Um, Number one, we're the first and only company that isn't just serving hospital systems, telemedicine clinics, urgent cares, private practices, IPAs, MSOs. Anybody who credentials doctors needs to do this, right? So
Yeah,
we have the credentialing suite that they can credential doctors. They can click and have the agents do the same thing the humans do regarding primary source verification. So we are going to have every state license instantaneously verified by the end of this month. And then we're going to be doing all these other things, FSMB, CAQH, all the things. But we're the first and only company that's giving doctors their data. So when you're credentialed, you have a wallet of your data and you can now take that with you wherever you go. So next time you credential, you share your credential as well as the data. So they probably want a primary source verified again because the Joint Commission, the NCQA forces them to, but it'll speed up the process because they'll have all the provenance data about you and your credentials, and they'll see, oh, it's already verified. Let's just verify it really quick again, and they could do it at a push of a button for a fraction of the cost of, the credentialing specialist. So that's one thing we're doing differently. Um, our pricing is also on the website. So it's baseline price, three practitioners. It's $2,999 a year for the software. That includes a generous token allotment, so you can, use the agents as much as you want, unless you use them an excessive amount, then you can add more. So it's kind of pay as you go after that. So I think it's about one third the price of the least expensive legacy software system that does not have AI agents. That's essentially a data repository. So we are the lowest cost, the lowest buy-in. Yeah, and then we actually have the AI agents that can actually do the primary source verification for you, and we have the audit trail. So those are the three things that we do differently. And the business model is for systems, practices to purchase the product, and the doctors have access to the wallet. You can have the wallet for free as a doctor, and you can have up to 10 credentials loaded up. You can pay $299 a year if you want to add as many as you want, if you want to get email notifications, text notifications, if you want to click and verify your licenses. Soon, we're going to offer licensing. So, medical state licensing, our agents are actually going to do that, the application for you. They're going to let you know, hey, you need to do these CMEs. Here's some options for you. We're going to do partnerships with CME companies to give you discounts on those CMEs. And then we're actually going to, we can't do the CMEs for you, but we can do the application for you. And so that's one of the things that we're going to be doing too. So we want to make it easy for doctors to have 50 state licenses if they want it, easy for them to quickly work at a telemedicine clinic or open their own private practice or work for a hospital. And then we want to make it
yeah,
easy for them to leave that hospital if it's not a safe or fair place to work and go somewhere else without friction.
yeah. Now, let's say a few years passed and everything was working great the way you have envisioned it. How long does it take to actually be credentialed at a place with your system working perfectly as you have intended it to?
We
How
believe
long does
weeks. We believe
oh,
weeks because there's a lot of things where we're waiting for humans on the other end.
hmm,
So even if we optimize everything in the instant that the, insurance company emails us, we instantly respond. There's still the human on the other end responding to us. Um,
hmm,
but who knows? We might get it down to less than that. We talk about credentialing, taking credentialing from months to moments.
yeah.
That's really the goal. The goal is to make it as fast as possible and to automate as much as possible without friction.
Hmm, hmm. So right now, what's the typical time frame you're looking at? So you want to bring it down to under a week. But right now, what is it? 1 month, two
Well,
months?
so we actually have in-house credentialing specialists that can do the things the agents can't do yet. So right now, all we have are state license agents. They can only verify the state licenses. We're working on doing all the other integrations, emailing, faxing, calling agents. The calling agents are going to be complex because they're going to have to communicate with people over the phone and then
Hmm.
coordinate with the emailing agents and the faxing agents, and so um, with our credentialing specialists, we can get you credentialed in a month now, along with
Hmm.
our agents. And we do white glove credentialing for our earliest customers who want to do that at a really fair price. So, yeah, so right now it's 30 days. And so on our website, you can actually look at a return of revenue and a revenue revenue capture calculator. So for every day over 30 that you take to credential, depending on how much each practitioner makes on those days, you can calculate how much money we're saving you by using our
Yeah.
system. It
Yeah.
covers it covers
That's
the cost of itself within one credentialing cycle by a lot.
wow.
Yeah.
Wow. Sounds like a very valuable service. Um, so what is next for the company? Are you raising money? Or are you in a growth phase? What's happening with the company?
We are in build mode and sell mode right now. We're
Hmm.
probably going to consider doing another round in the fall. Um, we're also discussing the possibility of doing some M&As with other companies that are similar, or maybe even doing a SPAC. So, you
Yeah.
know, what we want to do is put this in the hands of as many people as possible, optimize it as best as possible, and then we do need some more capital to kind of scale it up. And to optimize it and to make it hospital ready. Right now we're definitely ready for private practices, under 100 practitioners. Most of our current customers are under 100 practitioners, because they've been dealing with either legacy software systems or
Yeah.
spreadsheets and Dropboxes.
How much did you raise so far, and what is your next milestone?
I mean, next milestone is grow and get to a sustainable revenue. We still also want to get product market fit. There's a lot of things. We know that getting every state is very important. We know that getting the state coverage map is important. But what's more important to do next?
Yeah.
Is it end-to-end credentialing on the credentialing side with insurance companies, or is it medical licensing for the practitioners?
Mm.
We're building this to serve doctors, so we'd love to serve them, but we also want to build something that's going to be useful and is going to sustain the company so that we can
Same.
take that money and go lobby for interstate medical license and reciprocity. Even though that would decimate our business, I don't care because I think that that's what we need.
Yeah, maybe then you'll have like under 1 hour licensing
Yeah,
in
I
all
mean, that would
50
be good.
states.
More people would want to be doctors again.
Hey, thank you very much, Leah. If there is one piece of advice for physicians who are just entering, or even residents who are getting into residency, from your vast experience and deep knowledge and skill, what would it be? What would be one piece of advice?
Stay curious and build your own professional brand.
Mm,
Stay learning. Stay learning outside of whatever you're being fed and learn stuff that you love and build a professional brand around it. You know, if you're really interested in dry needling,
yeah,
learn that, talk about it online, integrate it into your practice, and you can do other things too, but kind of, you know, I think the combination of staying curious and building your own personal brand, I think is the best advice that I can give people. Yeah.
great, great, great advice. Um, Tell us, of course, we can find you on LinkedIn and other places, but feel free to leave other contact information. But what else do you do other than your profession and your business? What are your interests, other interests?
Well, I love my family. I'm here visiting them now in New York. I love to cook. I have a gravel bike, and I am a Pilates reformer addict.
Thank you so much, Leah, and you're welcome to stay back and answer questions, or you know. Do you have do you have some more
I'm
time?
happy to stay for, yeah, for 10 or 15 minutes for questions for sure.
Okay, let's see.
My pleasure.
Um, I'll say let's bring on people. I know there's a lot of questions in the chat and stuff, but let's see. Anybody wants to ask a questions, please unmute yourself and raise your hand. That way we can have you make you visible. Hey, team, can you get other people's videos here? I cannot see anybody.
I'm seeing
Is
one
there
about
gonna
this
be?
Texas foreign medical graduate. Um,
Yeah.
yeah, I mean, so one of the credentials is the ECFMG certificate that our
Mhm.
AI extracts and verifies. There's a new a new tool, I forget the name of it, that's an integration that we can build that automates that. And I think it's great. I think that, why shouldn't a foreign medical graduate be allowed to work under the supervision of a physician here? Um, I think that we have a perceived doctor shortage, and I know a lot of brilliant people that trained outside the US. So PAs can do it, NPs can do it. Why can't real doctors who practiced in other countries do it too?
Yeah. Yeah. This other question, the iPhone caller asks, why is the compact not for all states?
Well, so the interesting thing about the compact is it's it's the same reason that we can't get along as doctors, in order to be involved in the compact, you have to agree to their rules and their terms. And so
Hmm.
there's some states who are like, no, I don't agree with everything here. So for example, you have to be board certified in order to participate in the compact. So there's some
Hmm.
doctors who have let their board certification lapse. And so if every state joins the compact, all of a sudden you can't get a license unless you're board certified, which, that's essentially a restraint of trade on our right to work from my perspective. We went to medical school and residency, we have a license. Why do we need this other, you know, onerous, unproven task to complete on top of all that? So, um, that's my understanding. Now, I don't know the details of why certain states have not joined, but that's my understanding of why most of them who have not joined yet haven't.
Yeah. Yeah. The other question was about supplements and the evidence behind those supplements. What's your take on that?
Which supplements?
Clinical. Supplements in general, I say.
I mean, I think, vitamin A, D, E, K, you can die if you overdose on this stuff. We all know that who went to med school. And the rest of them you pee out if you don't utilize them. But I do think that they can help some people, especially people who have different deficiencies. I personally, my background's in molecular biology and biochemistry, and I really strongly believe in epigenetics. And I believe that there are some people who have essentially a deficiency in how they utilize zinc or vitamin C. And they might need extra supplementation in order to have the same effect that all of us, others get from their diet. I think in general, it's not really harmful. I think the only harm is when people are kind of just making money off of unnecessary supplements. And I personally take a lot of vitamins and supplements. I have a history of osteoporosis in my family. I take calcium, you know, I take
Yeah.
vitamin D. So it's just, I think that they're good for a lot of people. And I personally would like to start seeing more targeted epigenetic understanding of what supplements are better for certain people,
Yeah.
because I
Yeah.
do think some people could use help. Yeah.
Okay. So this last one just came in, and let's see what it says. Uh,
Oh, I'm looking at this. Somebody said that they uh went to the
will
emergency
you?
department, were billed
Yeah.
$7,000 for 15 minutes. Yeah, I mean, this is what I'm talking about, you know.
Yeah.
You billed $250 for a Tylenol when you can buy a bottle of 500 at Costco for $10.
Yeah.
That's the PBMs and the GPOs, my friend.
Yeah, exactly. This last question, last comment here. Will your product help physicians with completing the license applications, or will it eliminate the process?
So, as I mentioned, I would love to see interstate medical licensing reciprocity and essentially passed. The way for that to happen would either be at the federal level or each state would need to agree to essentially do compacts with each other. That's not going to happen anytime soon, you know? And we need to stay licensed. And I do believe that the medical board, for the most part, protects patients. I do believe having a medical license, I mean, I have some libertarian physician friends who are like, I don't care if you want to let your janitor do your appendectomy. That's not my problem. Just don't let me make me pay for the complications. I'm not that extreme, but I think that licensing the practice of medicine is what keeps patients safe. And even then, we have some bad actors out there. They're much less rare than people believe. They watch the Dr. Death podcast and all this stuff. Um, but
Yeah,
yeah, so my product is going to help you apply and maintain your licenses. We aren't there yet. That's something that's on the roadmap for next year. But until then, we can help you manage and maintain and prevent lapses in your license and remind you of expiration dates and things like that.
great. All right. Last question. We'll go to Rafael. Rafael, go ahead and ask your question. Unmute yourself.
Hi, Dr. Houston. Thank you so much for sharing your journey. I'm really inspired by really your passion for changing the mess that we have with misaligned incentives with our healthcare system, which just causes so many problems. So, my hats off to you for doing that. I'm wondering, you're a physician, probably not a trained business person or product innovator. I'm a product innovator, not a clinician, and so my mission is to help clinicians better build digital health systems and solutions, right? By using structured product development process, using some AI tools to really accelerate what they can do. I'm wondering, like, how you were able to enter the innovation ecosystem and figure out like how to build and who to get to build for you, and did you pay engineers? Like, what was sort of your journey so that people can understand maybe how other entrepreneurial physicians have done it?
It was a treacherous journey for a while because, I've always had an entrepreneurial sense. I used to flip cars in high school. I got into real estate investing. I've always had little businesses on the side my whole life. So I've always had that entrepreneurial, background. But trying to find a technical partner who understood and appreciated and was willing and wanting to execute on the vision that we had, it took a couple of rounds of people. Um, but with a combination of AI and finding our chief product officer, his name is Mark Lichman, who has really accelerated the product forward and has helped not only with a lot of the hands-on development, but has helped build Claude skills that allows me as an entrepreneur now I can go in and ask questions about my code base and ask questions about how people are doing. And none of my engineers write code anymore. They use Claude Code for everything. We use Claude Skills to develop the product. We have automated tests. We do have manual tests too for the QA and things like that, but it took a long time to learn. But again, as I said in the beginning, I think that's fun. I'm a weirdo nerd who likes to learn and likes being exposed to new things and new challenges. So even though there was some like bumpy parts of that road, it was fun and interesting to me to learn it. But I'd love to learn more about what you're doing. So, I think I left my email in the chat if you want to email me. We're always looking for great people too. I love working with great people who are really motivated. So, yeah, did that answer your question?
Yeah, absolutely. Thanks for sharing that.
Yeah, cool. Thank you.
All right. Thank you very much, Leah. Hope you have a good night and really appreciate your time here and educating us and sharing a lot of what you do. Thank you.
Well, yeah, thank you. What you've built is really amazing. I've always been appreciative of it and how much you do. So, thank you for having me. And thanks for listening,
Thank
guys.
you.
Ciao.
Good luck with everything.
Likewise.